Life sure gets busy, doesn't it? Well, we understand. With all the certifications you have, finding the right kind of continuing education that fits your schedule can be a real challenge. That's where the FlightBridgeED Podcast subscription comes in. For less than $5 a month, the FlightBridgeED Podcast subscription gives you top-notch accredited CE while you listen. Visit FlightBridgeED.com for more information or to sign up today. The FlightBridgeED Podcast subscription. Another way we're being your partner in discovery.
The content of this podcast is based on medical fact and evidence-based practice from credible, authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to be about you. This podcast is all about listener questions. All of these questions have been emailed to me, and I want to take the time to try to answer these in a simplified, very summarized format, because I think that if one person has a question, then many of our listeners have the same question. So let's jump in. One of the first questions that I want to touch on is, does a pH of 6.8 always mean this patient is going to die? Or better said, does a 6.8 pH mean this patient is super sick? I think the thing that we have to understand, and we'll use two different examples to simplify this. Let's say you have a DKA patient that has a pH of 6.8. We know that the DKA patients are very sick, but we have to understand that this is more of an isolated disorder. This is a sugar problem. Patients seem to tolerate a 6.8 much, much better than maybe in a sepsis patient. Even though that this is a plasma concentration pH of 6.8, the cellular disorder isn't really widespread. You take that same patient that has a pH of 6.8 and they're septic. These patients are highly, highly sick. Usually, and if you go back to the podcast I did on Goldmark, usually the patients that you see pHs less than 7 are going to be those ethylene glycol, propylene glycol toxicities, those aspirin overdoses, or those patients in ketoacidosis. Remember, ketoacidosis doesn't just mean DKA. We could have starvation, or we could have alcoholics. So when you see a sepsis patient with a pH less than 7, specifically 6.8 like this example, those patients should scare you to death. This means this patient has a widespread metabolic disorder at the cellular level. Again, cellular, widespread metabolic dysfunction, and they are globally sick, and these patients often die. So does a pH of 6.8 always mean the same? And the answer is no. DKA at 6.8 versus sepsis at 6.8, very, very different patient. What should we set the minute ventilation in acidosis? That's our next question. Well, here's the thing. If you've read our ventilator management at pre-hospital perspective book, we've actually done 2 editions. Our first edition, if you remember way back, and this is not something that I came up with. This is something that Scott Weingard taught 10, 12 years ago. And that is, start with a minute ventilation in a metabolic acidosis patient at a very high minute ventilation range. And that is 240 mils per kilo per minute. And I think as I have progressed in my understanding, and I have surrounded myself with other people that are smarter, and one of those is Dan Davis, Dr. Dan Davis. And we have had many, many discussions about this. So do we set that minute ventilation at that high level? And the answer really is no. And you've probably seen me pull back my thought process. In the ventilator book, I've brought that number down to 160 mils per kilo per minute. But I think as I have progressed in my understanding, in my comfort level, I've understood that A lot of times, again, a severe metabolic acidosis is very, very rare. And we should always look at, if we have it available, what is that prior end-tidal CO2? If you were to intubate a patient, they were maybe alert and oriented to the point where you could put a nasal cannula end-tidal CO2 on, get that standard end-tidal based on what they are doing prior to intubation. I think the best and safest approach is to honestly match whatever that end-tidal CO2 is, because we have to remember that that end-tidal CO2 is always going to be lower than your true PaCO2 on your ABG. So that is a safe way to play it. We also have to remember that we can do a calculation, and that is what's called the total respiratory compensation formula. If you go back again to my acidosis rodeo, part 1, 2, and 3, we go over a lot of this stuff. But that formula is 1.5 times the bicarb plus 8. And that is the maximum respiratory compensation based, again, on whatever that bicarb is. All right, let's go to question number 3. This is going to be a mechanical ventilation question. Hey, I just had this patient and their PIP was 60, but my protocol says that I want to keep that less than 35 if possible. What do I do in that situation? Here's the thing. If you talk to respiratory therapists, if you talk to physicians, there are many, many times where just to ventilate a patient, and usually these are those obstructive lung patients, just to ventilate them, you have PIPs of 70, 80, 90. And so we have to understand that a lot of times these numbers are meant to be a guide, but there are always those patients that make us have to step outside of those guidelines. And that's where, as you progress in your clinical practice, you progress in your knowledge base, you become maybe a flight paramedic or flight nurse. Your guidelines are going to become very, very broad, where maybe before you had pretty strict protocols. And that is because the acuity of these patients are so high at times that you can't have these rigid protocols. You have to be able to really think multifaceted in multiple different guidelines. So the answer is you should ventilate the patient based on what they need. The second part of this question we have to remember, and I get this question all the time, is how does our ventilator work in comparison to this high PIP? Well, remember, most ventilators are going to have a high pressure alarm, or I should say all ventilators are going to have a high pressure alarm, and that high pressure setting is going to basically terminate that breath. So let's say you had a PIP at 60. That would mean that you have to make sure that your high pressure alarm is set based on the ventilator. So let's use 2 ventilators for example. Let's use the Ravel. The high pressure alarm on that patient, if the PIP was 60, would have to be set at 65 because it terminates 5 less than what our high pressure is going to be. So if our PIP is 60, then it would terminate at 55 for that example. So if we knew we had a patient, let's say we are switching our patient over from the hospital ventilator and they were getting constant PIPs of 60, we can't have our high pressure alarm any less than 65 in that example. In a Hamilton T1 vent, it terminates 10 less than what our PIP is. So if your PIP is set at, or high pressure alarm is set at 60, it's going to terminate at 50. Well, maybe 50 isn't enough. Again, we have to think about this from the perspective of volume versus pressure as well. And really, when you look at a patient that's obstructive, for example, it's probably best to be in a volume breath. But again, that is going to terminate. Even though you have a tidal volume set at 400 mils, that breath is going to terminate 5 less on a Ravel or 10 less on a Hamilton T1 than whatever our PIP is. So if your PIP is at 60, it's going to terminate again less than that, and your breath may not be delivered. So here's the key is you need to make sure that you understand the parameters and the different dynamics of your mechanical ventilator. Next question. Should we use ketamine in the peri-intubation phase? Will it be the best option in that high shock index patient? Well, I've done many podcasts on this, and I know that there are a lot of studies going on right now on this exact question. Here's the thing we have to remember. The more and more we learn about medications, the pharmacokinetics of that medication, we have to understand that ketamine causes a sympathetic response. It does that by blocking muscarinic and nicotinic receptors. So by doing that, it increases our heart rate, increases that blood pressure. But let's look at the patient that you're taking care of. If you have a patient with a high shock index, and that shock index high would be anything greater than 0.9, you're going to take that systolic blood pressure, divide it into that heart rate to get that. That is the best indication for a decompensating, a very sick patient. Maybe that increase in sympathetic tone that you're seeing from that ketamine dose in that peri-intubation phase, maybe you're doing a 2 milligram per kilo dose. Maybe that's too much. So that's where we really have tried to kind of rein back and think about this from a broad perspective, that we can't just look at the dose and say, oh, RSI 2 milligrams per kilo. Okay, let's administer it. We have to look at that and say, okay, well, can we resuscitate our patients? Can we lower that dose and still get the dissociative effect? Well, the answer to both of those are yes. Ketamine probably is a great option in that peri-intubation phase, in that highest shock index patient. But whether you give etomidate or ketamine doesn't really matter if you don't resuscitate your patient. It comes down to slowing down, taking an extra 5 or 10 minutes on scene and resuscitating them prior, thinking about it from a global perspective. Can I lower that dose? Again, it doesn't matter the medication, honestly. It matters how you understand the medicine, how you understand your patient's condition, and that high index of suspicion you get based on how they are presenting to you. Your decision-making is what is going to make the biggest difference. Our next question, what is the best mode of ventilation? So I just got this email. I actually got a phone call about this. And if you've taken our review course, or if you've taken our mechanical ventilation course, I talk about this and I see the light bulbs come on. And I'm going to say this on this podcast. There is no clinical difference as far as evidence, as far as looking at outcomes on whether we use SIMV or assist control. This is always the hottest topic. But I will say this, and there is a but. This is where you get the difference in understanding in hospital respiratory care and transport respiratory care. When you look specifically at our transport ventilators, even though they are amazing, and you look at our mode of transport, whether that's ambulance or helicopter, and how these ventilators trigger, how the sensitivity is maintained. And most of these ventilators out there, not all, but most, are driven based on a flow trigger. And so what that means is this: our transport, the vibration, all the dynamics that come into play makes a difference. It's not that SIMV or assist control ends up in making a better outcome for our patient, but it's about the mode of transport. We don't have a patient sitting in ICU just sitting there well sedated, where they can be on assist control and not have any problems. We have a mode of transport where we have vibration from the aircraft or vibration from our ambulance. Maybe we have a lot of road noise from the ambulance. And so that's where the two modes make a difference. And it is always more optimal to use SIMV. And I will stand by this. And here's why. If you look at the two modes of ventilation and you paralyzed both patients, you had patient number 1 versus patient number 2, they're both going to get the exact same underlying mode of ventilation. They're going to both get a guaranteed minute of ventilation. Where SIMV comes into play and kind of protects us in this transport mode is this. Even if your patient is completely paralyzed and well sedated, you can still have activation of that flow trigger. And I show this in our class that basically if you calculate and do the math on a flow trigger, if you set that trigger at 3, for example, and I'm just using round numbers, the patient or the flow in the circuit has to change by 50 mils per second to trigger that breath. So it doesn't take much. It literally takes you shaking the vent circuit to change the flow in the circuit 50 mils a second. If they're in assist control, you're going to have a problem. You're going to have continuous, spontaneous breaths based on that flow trigger. What SIMV says is that every first trigger breath of a respiratory cycle is going to be assisted, and then everything after that is whatever the patient takes. Well, if they're already paralyzed and they're well sedated, and this is not a initiated breath by the patient, then there isn't going to be any more triggered breaths until that respiratory cycle ends. And then again, if there's continuous triggering, the first trigger breath will be assisted at the full mandatory breath. So there's a big difference there. In assist control, you're going to continuously get patient triggered breaths based on that flow trigger being set at 3, 4, 5. I've had 25 breaths above my set rate in SIMV with my trigger set at 9 because of the vibration of the aircraft. So I've seen this firsthand. How can we get around this? The one way to get around this, if you're dead set on assist control, is to always put your vent in a pressure trigger. That's one of the aspects of the impact ventilator. It's always pressure. The problem with a ventilator always in pressure, though, is those obstructive lung patients have a very difficult time in those types of triggers. So in that context, a flow trigger is much better. But in the majority of our patients, a pressure trigger will do just fine. So it's not that I push SIMV because I think it does better for our patient. It's just that it really does help in that triggering aspect. And I have taught mechanical ventilation, obviously, all over the world. And I've seen this from so many clinicians that have said they've had this problem continuously. So again, it doesn't change the outcome as far as what's best for the patient. Next question. Based on the current airway data in cardiac arrest, and if you've been listening to the Lighthouse Project podcast with Dr. Jeff Jarvis and Mike Verkest, they've been going through the PART trial. They've been going through the studies related to cardiac arrest and airway data and epinephrine. Great stuff. And when you start looking at the airway side of cardiac arrest, it's really, really intriguing to me when you start talking about, is a King airway or an endotracheal tube the best option? And ultimately, we have to look at this from the grand perspective. What does the evidence say? Well, the evidence says that a King airway is going to be quicker and with a higher success rate across the board based on the trials that have been done. Now, that is not a perspective based on specific services, because example, Air Methods has a first pass success of close to 92, 93%, right? So, but it comes back to training. It comes back to medical direction and how involved are they? How involved is the clinical education staff? What is the initiative, right? What's the focus? Let's look at this, though, from another perspective. And I get this perspective from our executive vice president of finance and development, and that's Joe Middleton. And he's also an executive director for an ambulance service. And so he brought this stuff up to me, and I think it's very valid. Obviously, whether you're an ambulance service, whether you're private or governmental, whether you're a hospital, money drives everything, right? Reimbursement drives everything. Just for an example, a Medicaid patient, right? And this is all about payer mix. Some areas have a very good payer mix. Some areas are primarily Medicaid. But you work a cardiac arrest. One of the things he told me is his reimbursement on a cardiac arrest for a Medicaid patient is $110. So let's just say that the crew decides, hey, we're going to place a King airway on this patient because it's quicker. And hey, we're also going to place an IO. Medicaid reimburses $110. Well, an King Airway is around $35, and an IO needle is $185. So they just took a massive loss on that cardiac arrest. Now, again, we have to look at, hey, we're treating a patient. It's all about survival. It's all about doing what's best for the patient. But what they just did, yeah, King Airways quicker. IO is probably quicker, better absorption. But you're seeing all these ambulance services around the country closing because they can't stay in business. They're losing money. They're operating in the red. It's because the reimbursement is so low. One of the questions we pose to multiple physicians is, why doesn't, if the King Airway is so quick, why doesn't the Emergency College of Physicians advocate for King Airways in all patients, whether you're a paramedic, a nurse, or a physician? Is actual intubation with an ET tube, not a King Airway. That is not the gold standard. It's not recognized as a gold standard. It doesn't have the same level of protection. So that's the key. It comes down to training. It comes down to individual service training. How involved are the medical directors? And so based on the question and based on airway data and cardiac arrest, which do you think is best? I think an ET tube is best. Really, when you look at the data, and if you've listened to the recent Lighthouse Project podcast that Dr. Jeff Jarvis did by himself, where he looked at the secondary analysis and they looked at the airway aspect in association with the epinephrine administration, and did that alter anything? Really, when it came down to it, whether you place an ET tube or a King Airway, it didn't change the outcome. It came back down to, as long as the epinephrine was in before that 10-minute mark, that's what really changed outcomes. So I think it comes down to that ET tube is always the gold standard. The training needs to be at the level that optimizes first pass success. All right, let's go to our next question. What is the best way to identify an anon gap? What is an anon gap? The standard jargon that you hear about an anon gap is this. What fills an anon gap is going to be lactate, ketones, and toxic alcohols. But when you look specifically at an anon gap formula, and we teach this all day long in our review classes, is looking at a corrected anon gap is an indication of either the absence of metabolic acidosis or a positive reflection of metabolic acidosis. And the standard corrected anon gap formula that we teach is this. Again, we have to remember the order of operations. So we're going to do the parentheses first. So we're going to do chloride plus the bicarb. Now remember, that is the serum bicarb. I'll come back to that. You take this chloride plus the serum bicarb, you add that together, you subtract it from your sodium, and then you add your potassium, because remember, based on the hydrogen ions shifting into the cell, potassium always shifts out of the cell into the extracellular fluid compartment, and that is going to cause a hyper-K state in a metabolic acidosis. So the more potassium that's present, the more indication that we have a shift, right? And that is going to indicate a metabolic acidosis. So based on the hospital, this is a variable based on where you work. Some places I know a corrected anon gap greater than 15 is a positive number. A lot of places it's 20. So anything greater than 20. Here's the thing, is that when you get down to the nuts and bolts, the best and most accurate way to identify an anon gap using the corrected formula is not using the K, but actually using the albumin factor. And I talk about this on the acidosis rodeo part 1, 2, and 3. And so to calculate an albumin factor, remember, albumin is a weak acid, number one. Albumin is a big part of what maintains our osmotic pressure in our vessels. It actually maintains about 22 of the 28 to 29 centimeters of water of osmotic pressure in your vessels. It's a protein. So when you look at that albumin factor, what you have to do is do a calculation. So you look at the normal albumin. Normal albumin will say is 4.5. You subtract that normal albumin from the patient albumin. So we'll say that is 3.5. So we have 4.5 as normal, 3.5 is our patient albumin. Again, that's in parentheses. We're going to subtract that, and we have 1 left over. And then you multiply that by 2.5. So that answer is 2.5. 1 times 2.5 is 2.5. So we would replace that 2.5 in place of that potassium. So instead of using that potassium, we're going to use the albumin factor. And that is a much more accurate way of identifying an anion gap. Now let's go back to the anion gap. And I said the bicarb is the serum bicarb, but we have to remember in the presence of a comprehensive metabolic panel, when we look at this formula, the bicarb is not the bicarb on an ABG. The bicarb is serum bicarb. And that serum bicarb, really the best, easiest way to identify, the way the lab identifies serum bicarb is by looking at the CO2 that's bound to that bicarb. Because remember, based on our acid-base formula, the majority of CO2 is carried in that bicarb, bound to bicarb. So 95% of that CO2 is bound to bicarb. That's the easiest way. So they basically identify that CO2 component, and that is the reflection of that serum bicarb. So when you look at a comprehensive metabolic panel and you see CO2, that is a reflection of serum bicarb. And I talk about this extensively in our laboratory values masterclass. All right, so let's go to our next question. Why does the hospital do something different than we do based on our current protocols in sepsis? Well, this is a hot topic. So we have to remember hospitals are all bound by CMS, and CMS is the Centers for Medicare and Medicaid Services. This is based on standard reimbursement, and usually what happens, and I'm just going to summarize this stuff, is that they have to look at each case and they weight this based on a score. And I'm not going to get into the whole score thing, but the national average, for example, I was just talking to my wife, is right around 58%, okay, of basically maintaining or adhering to that 1 hour sepsis bundle. And reimbursement is based on the hospital, based on that single patient adhering to that 1 hour bundle and matching it to our national average. So you as a flight crew member or a progressive ground agency may have the current practice employed in your protocols. You may be doing the current practice and you go and transfer a patient and they have done everything that's not moving towards that current practice, right? And it can be very, very frustrating. And I definitely have been in that situation. So here's what CMS says currently. So 1 hour bundle, initial resuscitation for sepsis and septic shock begin immediately. They have to measure the lactate. Now remember, lactate is a reflection of stress. And the difference that we have to understand is we have cellular lactate that is produced every time we have glycolysis. And our brain, our heart, our different organs utilize lactate as a biofuel. But we also have plasma lactate concentrations. And so anything greater than 2 is significant. So they're going to start antibiotics, but before they start antibiotics, they have to do blood cultures. They're going to administer broad spectrum antibiotics. So that means gram negative, gram positive. But despite the cultures being positive or negative, they're always going to start antibiotics. They're going to start rapid infusion of 30 mils per kilo of crystalloids for hypotension or lactates greater than 4. So if that patient comes in with lactate greater than 4, even if they're normotensive, they're going to get 30 mils per kilo. Now, I want you to know and understand what I just said. 30 mils per kilo of crystalloid. That means they could get LR, they could get normal saline. The majority of hospitals are still giving normal saline. And notice that that does not say ideal body weight. And that's a big problem. Because if I weighed 400 pounds, think about the volume I'm going to get. And that is what is causing problems. Apply vasopressors if hypotension during or after fluid resuscitation to maintain it or meet a MAP of 65 or greater. Remeasure lactate if lactate is greater than 2 on that initial test. So here's the thing. is that is much different than a lot of places, right? And you may have protocols now where you're not giving any normal saline in that resuscitation, or maybe you're not even giving a drop of fluid. Maybe you're doing passive leg raising. And I've talked about this on podcast, or using end-tidal CO2 as the gauge. You put a nasal cannula end-tidal CO2 on somebody, you do passive leg raising. If that end-tidal CO2, for example, is 25, you lift the legs. You give them a volume challenge based on the volume in their legs. Haven't given them a drop of fluid. And that end-tidal CO2 increases to 32. Well, they're volume responsive. You give them fluid, but we have to only give them enough fluid to make a change. And the fluid probably should be LR, not normal saline. So understand that CMS drives everything. And that even though evidence-based practice is what we should be focusing on, again, it comes down to reimbursement. It comes down to these hospitals have to have proper reimbursement. And it's going to take a while for CMS, again, Centers for Medicare and Medicaid, to jump on board. And I think there's a lot of politics. There's a lot of different people making those decisions, and it's going to take a while for that to happen. So this can be very, very frustrating. And I just wanted you to be aware of the dynamics behind the scenes on why this stuff happens. Let's go to our next question. Does an increased lactate mean anything? How do I use it? Well, remember, as I said, lactate is something that it has really evolved as far as what we know. And it used to be taught, hey, it's an indication of tissue hypoperfusion or a deoxygenated state. And that's definitely not the case. And we know that lactate is produced in normal amounts based on normal glycolysis. So whether we have aerobic or anaerobic glycolysis, we produce lactate. And sometimes based on the whole pyruvate and, Foam Frat did a great podcast on this where, maybe you just end up getting a little behind. You start producing more lactate, more glycolysis happens. We're going to produce more lactate as a response. And so lactate is a response to stress. The more beta 1, beta 2 receptor stimulation you have, the more glycolysis you have, the more lactate production you have. But lactate can be used as a indicator of that stress response. And it's still used as a indication of, hey, do we have lactate clearance? Do we have a drop in lactate? Maybe we're getting ahead of that disease process. But we have to also remember there's better labs out there. Procalcitonin is another lab. I've talked about that on other podcasts. So I think that it's important. It's something to look at, but it's not something to bet everything on. Even though I just went through that whole 1 hour sepsis bundle, we have to use it based on current reimbursement. But there's other tools, there's other indications with our patient that we can look at. Next question. What should we do with sodium bicarb? Should sodium bicarb be utilized in metabolic acidosis? Here's the thing. I've done podcasts on this. I think the evidence is out that sodium bicarb in the majority of patients is probably not the best option. But really, when you have a patient in renal failure, you have a patient with a low urine output, or you have a patient with a pH less than 7.2 in a lot of places. Some places may say less than 7.0. I think it's indicated to use sodium bicarb. But remember, you can mix this in a much better way than just giving a full amp of sodium bicarb and mixing it with a standard 8.4%. And so the best way to do that is just to simply mix that 1 amp of sodium bicarb in 50 mils of D5W. That's going to give you that 4.2%. And so you're not going to have that huge CO2 load. And that is the key, is remember, based on the acid-base formula, CO2 ends up as bicarb. It is carried in bicarb. So the more bicarb you administer, that acid-base formula goes the opposite direction, and it basically metabolizes, turns into carbonic acid. Carbonic acid splits off into CO2 and water, and so we have more CO2. So essentially mixing it in this way, giving a smaller percentage at 4.2%, you're not going to have that high CO2 load. And so in some cases, it may be indicated, but remember, you will always have that CO2 load if you mix it in those higher amounts. And I think it's always a good option to think about that higher respiratory rate just to make sure you're offloading and blowing off that excess CO2. The next question is going to be, what is the easiest way to identify metabolic acidosis without point of care testing? the majority of our community-based services out there in the United States that does not have point-of-care testing, and they're flying into these rural areas, and you guys know that. And so we have to remember that sometimes we have very little information, and these are just little tricks. If you calculate an anon gap, as we talked about in the earlier part of the podcast, and that is, let's say, greater than 20. I've always been taught to use 20. Some hospitals may use a lower number at 15. That is an indication of metabolic acidosis, even if you have an ABG that's normal. So that is important. That anon gap being high is going to be the earliest indication of metabolic acidosis despite a normal ABG. So that ABG is going to be a late type of an indication. Another way, this is something that I learned quite a few years ago from Scott Weingart, is to simply look at the bicarb, the serum bicarb on your comprehensive metabolic panel. Remember, that's reflected as a CO2. And take the CO2 and subtract it from 24, and that's going to be a calculated base deficit. And so remember, a base deficit is a negative base excess. On a base excess greater than -2 is an indication of a metabolic derangement. All right, next question. What is the best way to resuscitate my burn patient? I get this question all the time, and this is where we have conflicting types of information. When you look at the FPC or the CCP-C or the CFRN and CTRN, we're still testing our flight crew members on the Parkland and consensus formulas. And here's the thing is, I just did a course down in Dallas, and I was talking to one of the burn coordinators at Parkland Hospital, and you know, they're like, we don't even use a Parkland formula. We haven't in a long time. And I think that we have really seen in medicine that normal saline by itself is a bad fluid, right? And that's where we get into that whole iatrogenic saltwater drowning. So here's the way we have to look at this. Testing is one thing, but when we look at standard resuscitation, it's this. On any adult patient, focus on 500 mils per hour. So on that 911 call, you have a burn patient, 500 mils per hour, no matter what, 500 mils per hour. And you're not going to get 500 mils in. 500 mils per hour is what you set it at. You may only get 250 in. 500 mils per hour, no more than that. They're going to evaluate the urine output at 1 hour. If the urine output is between 30 and 50 mils per hour, which is our standard goal outside of rhabdo, if rhabdo is suspected, 100 mils per hour is going to be the goal. If we're not meeting the 30 to 50 mils per hour, we're going to increase our overall amount of fluid per hour by 20%. So we're going to increase it to 600 mils per hour. If the urine output is normal, we're going to leave it alone at 500 mils per hour. If it's high, if urine output is high, they're going to decrease it by 20%. So they're constantly evaluating by the urine output on an hourly basis and fluctuating the fluid based on simply that. And that is how you should do it. Right? In kids, if the kid is less than 10 kilos, your goal is 2 mils per kilo per hour. If they're greater than 10 kilos, it's 1 mil per kilo per hour. Again, in that adult patient, you're going to focus on 100 mils per hour in that rhabdo state or suspected rhabdo state, and 30 to 50 mils per hour is always the gold standard. So that is the questions that I have, guys. And again, thank you for emailing me all these questions. I constantly get emails every week. I try my hardest to answer these emails within 24 to 48 hours. Obviously, there are times that I'm traveling. And again, thank you so much for continually supporting FlightBridgeED, for believing in us and believing in the mission. We are so indebted to you and so thankful that you have chosen us for your education. If you have any questions, any ideas for podcast, please email me at eric.bauer@flightbridgeed.com. And we look forward to seeing you at the next class. Thank you.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.